service learning taps into what I think is really the core mission of who we are as human beings and as doctors. And the doctor part is just a privilege. It's just one vehicle to do what you think is important, which is to help people. So I don't diminish the value of reading all the books behind me. Yes, that's one part of it, but really, I would emphasize that's not the important part of who you are, either as a person or as a doctor. And let me give you a very clear example of why service learning in the community with the people who you will see later on as patients, we hide behind service learning, social determinants of health is important. I get all of that, but those are theoretical. Let me make this very personal and very basically selfish for each one of us, right? So I see some of my favorite doctors here on this call, Dr. Furstein and others, but they will all tell you, sometimes you get a patient with a very simple question. I'll take hypertension, right? Right now, all of you can diagnose hypertension, correct? You can even use one of those electronic cuffs. You don't have to do anything. The patient will say, yep, blood pressure is high. So we got the diagnosis correct. And you can look up and find a simple standard treatment for it, which is effective. So you got the diagnosis right, you got the treatment right. How many of our patients, of the 100 patients you would see in your service learning, how many of them will take the medicine and do well in 6 months? Somebody want to guess? I'll give you some choices. 100%? No. 75%? No. 50%? No. Hey, come on, guys. Does anyone get better?
I guess 50.
You guess 50. Yeah.
20.
So actually the data suggests that with a simple chronic illness, such as hypertension, where you got the diagnosis right, you got the treatment right, if the person took just one pill a day, they would feel better and prevent all the other problems we get down the road, strokes and heart attacks and all of that. About 50% will take their medicine. So you can read all the books. It's not going to help the 50% who won't take their medicine. And I see that as service learning. I see that as this is when you're going to learn how to understand that these are not bad people. They don't really want to have a stroke down the road. This is where social determinants comes in. This is where being human comes in. This is where you learn about someone not having money or having no time or all the simple things that make us human. So I would argue today that service learning is not an altruistic thing that you do and check a box and write an essay at some point and say, I helped all these people. I went into the poor neighborhoods. I'm a good person. All true. Actually, what you do is very valuable. And I don't mean to diminish that in any way. But more important is what you get. You will at the end of this be richer than the person you worked with. You will learn the next time someone comes in and you say, I don't get it. I know you're a sensible person, but you're not taking care of yourself. A very different question from you're non-compliant, you're non-adherent, we just quickly blame the patient and walk away, feeling very good. I did my job. I didn't. If my patient's not doing well, I failed. We can blame the patient as much, we can blame society as much as we want. The fact is, my patients don't get better. And so if you're going to judge me on how good a doctor I am, I failed. Just off the bat, 50% of my people are going to fail. And then off the 50 who take the meds, you're going to run into some that'll break through and don't do as well. And you'll switch meds and you'll add meds and you'll do tests. But you're starting with a 50% failure rate. And that's a simple thing like hypertension. It's shocking, but people with a diagnosis of cancer don't follow through 20% of the time. the C word, we're all convinced that we would absolutely do everything to take care of ourselves and live, but we don't. So I would like you to think about your better angels, to think about why you wanted to be a physician, a healer, and that being a physician has significant portion of classroom work, but being a true healer is being out in the community, reaching out and understanding people, in being able to connect to people rather than blaming them, in being able to ally and to work with them to overcome whatever it is that is not allowing them to take care of themselves. And honestly, it comes down to that simple recipe. And I would say to you, it's wonderful that you're here because you're already interested. You've already tapped into your better angels. But at the end of this, your patients you work with, or the people you work with, or the students you work with will be better off. But I guarantee you that you will be 5 times richer than they are from this experience. And I see this as not just an add-on experience. You know, this is not extracurricular, as you wrote in your essay when you were applying to med school. I see this as absolutely essential to being a doctor, to being a healer, to being a good person, working with another good person, to do the best you can for them. So thank you for what you're doing. I know the great work that Simone has shepherded all these years. Again, I know it's sort of separated out as a Center for Civic Engagement. I would love to call it as sort of a center for just continued growth, your growth, not giving, your growth. It's as important as eating right that we were discussing. It's as important as exercising. It's as important as wellness. It's really core to you doing the best work you will for the rest of your life. So this is going to be a very small investment on your part that I assure you will pay off big time. So thank you very much again. I would look forward to hearing about all the wonderful things you do. And every time we sort of walk through the posters, I'm always impressed at how amazing it is, the impact that you make, the work you've done, the creativity. So thank you for all of that. That does help the community, but I'm also most excited to see how you grow.
Thank you for that, Dr. Dewan. Very important message. We are going to go ahead and get started, and I'm going to kick it off with a quick overview of all of our accomplishments for this year. So the COVID-19 pandemic has undoubtedly tested us this past year and forced us to think outside the box, especially when it comes to service learning and our programs that we've been able to develop over the past couple of years. I will admit I have lost a lot of sleepless nights to try to figure out exactly how do you do service learning at a distance. But thanks to a very persistent staff member, Ms. Nakeia Chambers, and the willingness of our student leaders, our community partners, our volunteer doctors, and their willingness to be flexible and creative, we wanted to give it a try anyway. And we actually ended up with some really unique learning experiences, some of which you'll hear about today. But despite the challenges, we were able to accomplish a couple of really important milestones. Thanks to the efforts of over 200 student volunteers, we actually logged over 7,000 hours of service in a year. And this time period starts from January 1st of 2020 to January 31st of this year. So that translates into an economic impact of $212,000 just within that year. We were also able to have about 65% of our student volunteers assigned to COVID-19 volunteer opportunities across our campus, which definitely helped with some of the COVID-19 relief efforts that were underway. Our students pitched in and came up with projects, helped out with remote experiences at the hospital. They made masks for the homeless, you name it. They came up with it, and we at the Center for Civic Engagement did our best to try to support them with any initiatives that they came forward with. We were also able to train 24 service learning leaders from who you will hear today, with the focus on working with diverse, underrepresented population as community-oriented physicians, using a team-based approach to problem solving, and also being reflective practitioners. And the students will know that I always tell them, it's great to be involved in a service activity or to do something, but what are you learning from that? And how is that making you a better person and a better future practitioner? We were also able to launch the Rural and Underserved Service Track, TRUST at Upstate for short, thanks to 5 of our medical students who participated in this pilot this year. TRUST is a collaboration between Binghamton University's College of Nursing, College of Pharmacy, and their Department of Social Work and Upstate to be able to train our students to work interdisciplinary as part of a service program that was started at Binghamton and we were invited to participate in. This is our pilot year, and we're looking to expand hopefully next year and to roll it out formally to our first years, and hopefully our Trust Scholars who participated this year can remain on and help mentor the first year students who will be coming on board. The Trust Scholars, as they're called, focus on the developing competencies that you see listed here, but more importantly, they're also being trained to work as an interdisciplinary team. So Trust has 4 learning retreats, 3 of which have happened this year, focusing on different population and content area, but they're integrated with different disciplines to be able to discuss a case study related to a specific population and to really learn from the different disciplines how you would address this issue as a team. So we're looking forward to rolling this out, hopefully in the fall, to additional students. The didactic and reflective component of the service learning program allows students to earn 2 elective credits. So the service learning leaders are responsible for developing and implementing service projects while also recruiting and mentoring student volunteers to participate in their respective programs. Unfortunately, due to the COVID-19 pandemic, many of our service activities had to be either modified or changed completely, or couldn't get off the ground for various reasons and challenges. But the students were still able to do some amazing work and participate in alternative opportunities that still were very impactful in the community. The course content and the roundtable discussion series, which were facilitated by Armando Martinez and Stephen Contreras from Student Affairs, they focused on a lot of the topics that you see listed here. So, what are the ethical implications of service? Again, you're bringing your lens to a service opportunity. What does that mean for you? What does that mean for your community? What does that mean for your future career? Health disparities and looking at the root causes for those health disparities and where they stem from and why. Health at the intersection of race and poverty, structural racism, the list goes on and on. But we also allow students to, provide an opportunity and space for students to discuss current events and just provide an open dialogue series for students to share insights, lessons learned, and things that they wanted to discuss as a group. As part of the course, we also had the Death Gap as our required text, which was written by one of our own alum, Dr. David Ansel, which also provided valuable materials and content for online discussions that students also participated in. So they were very busy this year. So with that, I want to turn it over to our first group of students to share about their experiences this year.
Okay, so we're group 1. So I am going to go first. So along with Sarah, headed up the Extended Hands for Adolescent Mothers service learning opportunity for this year. So just to talk a little bit about the things that we faced and some of the ways that we were trying to overcome it. we ended up doing a pen pal program because usually EHAM is a program in person at the Salvation Army with TAPC, working with adolescent mothers, just talking about mental health, things that they face and maybe financial things they face and kind of everything except for sexual health, because that's what they get a lot of on the day-to-day basis. So we were trying to figure out how to do that remotely. There were a lot of barriers with technology. The Salvation Army wasn't able to provide any like consistent like webcam access or any way for them to communicate consistently. So we weren't able to do a remote virtual version of the program. So Sarah, I cannot take any credit for the idea, but she came up with the pen pal program that really turned out to be something that I like. It became something that really was a great replacement for what we couldn't do prior to that. So we essentially just recruited any students that were interested in mentoring / being a support system for the moms in this time. And we coached them through, what could you write in a letter that would be helpful to the young mom? And we were able to get contact information for them. So they were able to either text or write letters or anything like that. So we coordinated with TAPC and were able to find a couple girls who were interested in the program. So that is still going on. It's a longitudinal program. So the people who did sign up are able to continuously coordinate with the moms. So it's really, really cool thing that we were able to do. We were really thinking about, what are the needs of this population? So being adolescent mothers in COVID-19 is just a lot of superimposing, deficits, if you will, or just like things that a lot of challenges that they have to overcome. So we were wondering what would be the best way to give them what they would need. So we talked to the Salvation Army and they were really emphasizing this idea of mentorship and somebody there to support the moms. So that's what we kind of went with. And then we thought the pen pal thing would be a nice, like personalized touch to be, interactive with the girls at a distance. So I think it went pretty well. Yeah. I can go next slide now. Who's next?
Okay, I'm the leader. I'm a service learning leader for medical education for diverse students. And there are actually 4 other leaders along with me on this Zoom. So if I miss anything, please feel free to chip in. So basically just an overview of this, we're a program where we have high schoolers from local Syracuse high schools come in every month or so. And we will have workstations every month with them where we teach them on renal, basic life-saving procedures, on the heart, on lungs, musculoskeletal systems. So we sometimes will get to use a sim center to use the heart and chest, to use the heart mannequin and get to insert chest tubes. So I think the high schoolers had a lot of fun doing it, and we had a lot of fun teaching and hanging out with them. We also would have guest speakers at the end of every session to talk about medical fields and how to get into them, because these students tend to come from schools that are more underserved. So we want to expose them more to how to get into a medical profession if they're interested. And even for me, it was actually emotionally really rewarding for me to be able to see the high schoolers become more engaged in topics that are actually very academically challenging, even for me. So even for me as a medical student, it was very difficult to grasp initially, but then they became really engaged and very invested in our topics, and we will have trivia and they will all be really eager to answer. So that was very emotionally rewarding for us. And also it was nice to feel closer to community in a way that's not strictly being a medical student here at Upstate. It was really cool to connect with local residents of Syracuse because I'm not from Syracuse, so it was really interesting that way. Also, I think from that experience, I got to learn how to talk about medical concepts in a way that's easier for people to understand who are not medical professionals. And I've used that in talking to my SPEs as well. And I think that's really helped in getting me to become more approachable and a better physician in the future. But so this year we actually had some issues with launching our program because of COVID, but Didier is going to talk about that in his presentation.
Hello, so I'm Tyler. I'm one of the SLLs for Helping Hands for Forgotten Feet, along with Dan, Julie, Anna, and John. For you guys who don't know exactly what it is, it's basically we run monthly clinics through the homeless shelter at the rescue mission, and we provide the residents there with like basic health screenings, especially relating to like their podiatric complaints, or and then we do screening for like diabetes and hypertension as well. So since we started in August, I think we've held 3 clinics. And I guess so the challenges that we face, not so much physician coordination, but it's some of the podiatrists are a little bit hesitant about being at the homeless shelter. So it's kind of been difficult getting them to come in. And I mean, it's understandably so. It's, you know, they have kids at home and stuff, and it's kind of not the safest place for like COVID wise. And then otherwise it's challenges just COVID in general, you know, figuring out a plan on how we can run the clinic safely for individuals, you know, making sure that there's social distancing and that we can enforce like mask wearing as much as we can. And then I guess some of the strengths that we had compared with previous years, or at least last year from my experience, is that we had a lot more interdisciplinary like attendance. We had a lot of PA students, we had some graduate students, which is definitely pretty cool considering last year it was mostly other medical students that were showing up. And then also because of the way we were implementing our social distancing, we were able to increase the patient's privacy. So we have like this small room upstairs in the 2nd floor of the rescue mission. So sometimes it can be difficult to keep, you know, HIPAA confidentiality with the patients, but now we were able to move them and separate them into like other rooms so that we could see them more on like a one-on-one level.
Hello, I'm Katie. I was one of the service learning leaders for Reading Buddies this year. It was a challenge. A lot of it kind of came down to COVID. I mean, seems to be a recurring theme. But I guess the purpose of Reading Buddies is to help facilitate reading and language learning in young students in the Syracuse community. And historically, what had been done is that students from upstate would mentor young students at a school district or at an extracurricular site, I guess you could say. And this year we were working with a new site, and between logistics and COVID, it didn't really get off the ground. One of the challenges is that, you know, we kind of had different ideas for the program, I think, than the site did. So that kind of proved to be a little bit of a barrier. But I think one of the things that we did well, to Kenny and I, if you have anything to add, feel free. But to Kenny and I, and Simone and Armando as well, I think we did a really good job communicating. And we really built like a strong, trusting relationship amongst the 4 of us. And I think we worked well together as service learning leaders and supervisors.
Okay, so we'll get into the topic. So we did our vaccine hesitancy topic on rural America, and just a little bit of information on why we chose this population. So we were looking at a study that was really recent. I'm sure a lot of people used it, by the Kaiser Family Foundation, that was done just in December, or actually maybe this month, but it kind of talked a lot about the different groups that are vaccine hesitant and why they're vaccine hesitant, and just the different sectors of like vaccine compliance and things like that. So within the rural community, I just put a couple of stats on, you know, specifically in COVID-19, a lot of the households reported not being able to get critical care if they needed it, if they had COVID-19, and they weren't able to get general care even before COVID-19 if they had a serious problem going on or things like that. So it's really like, you know, the access superimposed on the prevalence of chronic conditions that, makes them a more vulnerable population. And then, they don't have as much opportunity for healthcare education because they don't have the access to be seen by providers. So that kind of disconnect is contributing even more to their vaccine hesitancy. So looking at these stats, we definitely realize that it's all the more important to learn about vaccine hesitancy, because it is our responsibility as physicians to make sure that we're understanding that there are certain aspects of a community that might, be hard to overcome for the community itself, so we can be of service to help them bridge that gap and get the healthcare that they need. So I did a little looking into like the history of vaccine hesitancy in rural America, and I couldn't push it too far back, but I was looking at the flu vaccination rates, and I found this infogram. Okay, perfect. So I was looking, so it says rural counties have some of the lowest flu vaccination rates. So this infogram is kind of comparing the vaccination rate to the amount of rural qualities that the community has. So you can see a very stark decrease as you get more rural, these outliers down here just being very, very low in vaccination rates, all the way at the side of being the most rural communities. So it is a really profound decline of rates. I'm going to go back to the PowerPoint. Wow, that was very smooth. But so looking at that, you can kind of see that the vaccine hesitancy isn't a new thing for COVID-19. And it's important to understand these trends don't just go away with the new disease. So it's important to continue to look at the history of these populations and look at why they might be feeling these adverse feelings toward vaccines. So one of the things that we kind of gathered from some of the staff and some of the anecdotal studies is that rural communities have a collectivist mindset when it comes to many different things within their communities, but not necessarily when it comes to vaccines. They see it more as an individualized choice. So bridging that mindset with the things that they see as more collectivist within their society or within their communities is important to kind of like make sure those two things are coming together nicely, and they understand that those are very similar in the way that they share food and the way that they protect each other from diseases. So, yeah.
Sorry, the picture was a little large, but it's kind of hard to see, so I wanted to make it as big as possible. So this figure kind of shows the prevalence of COVID-19, the cumulative prevalence of COVID-19 nationwide. And as you can see, a lot of the more concentrated areas of COVID cases are really in rural communities, especially like up in the Midwest and northern Midwest area, as well as parts of Texas. And I think that's Nevada over there. But, a lot of times, you hear about the big metropolitan areas getting hit, but really the rural populations are getting hit a lot as well. The next slide. So in rural communities, a lot of the problems with COVID come with getting access to care. To expand on what Jada was saying, especially during the pandemic, there have been limited appointments. The access to healthcare providers has been limited, and they're kind of stretched thin as well in rural areas. Also, the cost has been an issue. Based on a study done by the Robert Wood Johnson Foundation and the Chan School of Public Health at Harvard, the cost and as well as insurance not covering specific providers has been a big issue in the rural community. Also location, as you can imagine, if you're really far from your provider or the nearest provider, wherever that may be, it could be very difficult to get there, and not everybody's able to do that. And according to the study that I was mentioning before, nearly half of rural households have at least one member that's considered high risk of having a poor COVID outcome, which is a lot of people. And then a couple issues that are less directly related to healthcare outcomes, but can definitely have an impact, are connectivity issues and financial problems. So as far as connectivity issues, almost half of rural households said that they used telehealth in some way, shape, or form during the pandemic. However, again, about half of rural households have trouble with connectivity problems, and especially when you compound school and medical appointments and work and everything, that really magnifies the issue. And then for financial problems, one thing that they reported in this study is that 85% of Black and Latino rural citizens reported having financial hardships during this time, compared to 36% of white rural households, which I thought was really, really staggering. And it just kind of shows that, you know, difficult times can really magnify systemic issues. You can go to the next slide. So like Jada was saying, more rural Americans than any other either suburban or urban community are less likely to get the COVID vaccine. Part of this is they're less likely to know somebody who's gotten COVID or tested positive or has died from COVID, because the population density tends to be lower. They are often less worried about themselves getting sick. And like Jada said before, about 2/3 of the rural population says that they believe it's a personal choice, more so than view it more as a personal choice than as a responsibility to protect others. Whereas if you look at the stats for urban and suburban communities, it's the exact opposite. And about 2/3 of those communities view it's their responsibility to protect others. Another factor was exaggeration of COVID in the news. And about half of rural Americans believe that the threat of COVID-19 has been exaggerated in the news. And also there's a lack of trust in the vaccine. There's a good article put out by the Wisconsin Public Radio, and they had somebody mention that they kind of wanted to wait and see what happened with people that got the vaccine to see if it was effective or if it caused any issues that were unforeseen.
Okay, so in order to address all these issues in COVID vaccine hesitancy in rural communities, we decided to propose 3 different strategies. So we actually utilized the WHO fact sheet on building trust for vaccinations in communities, and we focused on the build relations segment of this fact sheet. So we're going to go into detail in each of them and talk about how we're going to do it.
Yeah. So on the relationships tab, it talked about using important stakeholder groups as a way to combat vaccine hesitancies in the groups that you're trying to target. So, like I was saying, so one of those important stakeholder groups I believe to be rural physicians. So some of the data from the Kaiser Family Foundation showed that the individuals in rural America were much more likely to trust their physician about vaccine information when compared to these larger institutions and organizations like the FDA, the CDC, and health departments. And then I guess like Katie and Jada were saying, it's been seen that rural individuals need to be a little bit more convinced of the severity of the disease, and there's multiple different strategies that rural physicians can implement to do so. Just to name a few, we can they can organize forums with local churches and governments. You can utilize social media to promote their message, and then there's also multiple organizations such as like the American Academy of Family Physicians and the AMA that have resources that are available for them to combat vaccine hesitancy and have that talk with their patients. You can go to the next slide. And you can go to the next one after that. So the World Health Organization was also talking about how you can utilize the media to build relationships and to target the audience that you're trying to target. This can be especially difficult with rural Americans and a little bit disheartening, especially when your audience is consistently misinformed by the media outlets they partake in. Like Katie was saying, a lot of rural Americans believe that the coronavirus is blown out of proportion. And that coincides a lot with the Republican take on the issue, I believe, and that's in contrast to urban Americans and Democratic Americans who believe that the COVID virus has been less exaggerated. So simply, some of the ideas for targeting the media would just be to target ad buys in these conservative media outlets, such as Fox News, and that can be to increase the accuracy and capacity of the facts that these networks are showing. And then on a side note, you can also increase the capacity of fact-checking outlets that overlook social media and the news, and et cetera. And then another thing I kind of wanted to talk about was, and this is kind of interesting, is the Ad Council was recently given $50 million to promote the COVID-19 vaccine and kind of combat vaccine hesitancy. And they're doing so by recruiting like influencers and prominent figures to promote the education and eliminate this hesitancy. And in the bottom right, one of the actions by the Ad Council was actually to get Mike Pence to receive the COVID-19 vaccine on national television.
So the final point, we will be addressing the WHO suggestion on being visible to increase public knowledge of immunization and trust in your spokesperson. So we want to establish vaccination sites and structures that local residents are comfortable with. So according to the vaccine hesitancy chart that the WHO came out with, convenience issue is actually one of the 3 major factors deterring people from getting the vaccine. People might say, I really want to go to vaccinate my kid, but I have to take a day off work and it's so far away. So then we want to utilize facilities already frequented by rural residents, like local Walmarts and schools, so people can just do it on their way. And also this is a more familiar place for local residents, so they might feel more at ease and feel more in their element when doing this. So this also leads to like less structural barrier to obtaining the vaccine for the rural residents. So that's the end of our presentation. Any questions, comments?
Thank you, guys. That was very thorough. If there are no questions for that group, I'm going to move on to our second group.
Can I add something, Simone? It's Barbara.
Go ahead.
Or are you in a rush? I just have one thing to say.
Go ahead.
Oh, okay. So I had a student shadowing me virtually on Thursday, and my patient who's had type 1 diabetes for 39 years, and she's 1 year old and she's 40, really needs to get the vaccine, but she was really anxious and didn't think she was going to get it. Luckily, the student who was in on the virtual visit with me convinced her to do it. So you students have power to really meet people where they're at and make a difference. So you just never know where you'll be, have that, where that power will show up. But I was so grateful the student was with me that day.
Great. That's a great example. Thank you for sharing.
All right. So we're the next group presenting, and I know y'all just heard about some of these learning opportunities, but I wanted to share what I learned from EHAM with Jada. So you heard Jada talk about how we had to completely restructure basically the entire service opportunity due to COVID restrictions. And so in doing so, I actually got to use a lot of the lessons that I learned from class, right? And from the Health Justice Conference that happened recently. But one of the key things that I learned from this class is that volunteering is not necessarily about, quote, helping a community, but rather meeting them where they are and supporting their endeavors however we can, right? So what we use that for is through our workshop meetings, right? So Jada and I came up with this pen pal idea along with a few other ideas and presented those to not only Simone, but to TAPC through meetings. And through those meetings, we got to the core of what this community actually wanted from us and actually needed from us. And we were able to workshop our program in order to best support them. And so don't believe Jada when she says that she doesn't deserve credit in this idea. She does, because she fully helped. And then from running our program, we obviously encountered some obstacles. Our volunteers were very excited. So we had quite a few signups on the upstate side to volunteer, but getting women from TAPC to participate was a little bit difficult. There were some communication issues with women at TAPC not living in the house due to COVID. So it was hard to kind of get that, get the program advertised to them. We did get one woman we did make one pen pal partner, and that seems to be going excellent. We're in the process of connecting another. We're hoping that as this program continues, this word of mouth will help expand the program. And this program is brand new, and it'll take time to work out the kinks, and that's okay. That's another thing I learned, is that service takes a long time. It's not an immediate overnight, this is great, we fixed everything, because we're not there to fix everything, right? We're there to work with the community and help support them. And then finally, I wanted to talk about some of the other opportunities that I was able to participate in through Center for Community Engagement. So one is Reach One, Teach One, which the service learning leaders aren't in this class this year because they took it last year. And from Roto, one of the biggest things that I learned is that our Syracuse community, the kids need more opportunities to grow their love for science. And because they truly are so into science, and they are so intelligent, and they're so passionate about becoming healthcare professionals and scientists in the future. And while Roto is a fantastic opportunity and it's a great start, I'm hoping that as an upstate community, we can continue to offer these opportunities and continue to create a culture at upstate that gives these kids a chance to benefit from the fact that there is a fantastic medical university in their neighborhood. And then I was a COVID runner, and I was a big part of the Health Justice Conference. So all of these programs were kind of invaluable in my first year in the medical school. So I wanted to say thank you to both Simone and Nakeia for teaching me so much this year. And I hope to continue using these lessons in the future.
You're welcome.
So I'll be next. My name's Maria, and I'm the first person to speak today from Rama. We have a couple of us going. So for those of you who don't know, Rama is just a primary healthcare clinic located on the south side. And we were actually reopened in July, which I'm sure Rob will talk about. He had a lot to do with making sure we were up to protocol, and did a really great job so that we could reopen. Unfortunately, we had to close again mid-November, but we have been conducting visits through telehealth on a more limited scale. We all kind of had different projects that we wanted to accomplish during the year. And for my project, I really wanted to work on outreach because we've known for a while that we could sustain more patients than we're currently serving. And we kind of wanted to see if we could grow and reach more patients, especially within the South Side, because there are a lot of people right near the clinic who don't know we exist. So that was something that I really wanted to try and work on. We were handing out surveys to assess how our patients had heard about the clinic, and we started to work on some things to host a focus group, but because of COVID, we really feel that the focus group would be best in person. So we kind of put together plans for that, but are waiting to see if we could do that if COVID gets a little better in the future. And as far as lessons learned from trying to do outreach with the community, it can be extremely difficult to find ways to conduct outreach. And I think I really learned that the best place to get input about how to reach the people you're trying to reach is the current people you've already reached. So we really wanted to speak with our patients and community organizations. We talked to Osha Keating after she spoke to the class about her thoughts about how we could reach out to people who might be able to utilize Rama services, and that was really valuable. So just basically going to the people who know best and talking to them gave us a lot of good ideas. And also the added challenge of telehealth makes it really difficult to recruit right now because that's a barrier to access in itself. So we don't want to conduct a ton of outreach to people who might not be able to do a telehealth visit because they don't have access to Wi-Fi or some type of device. So those were kind of things that were setbacks, but I think overall we were able to have a lot of first years come in up until November, and I think a lot of people got to experience Rama, so I was happy about that. And just one other thing I want to add that I forgot to put on the slide, I was a service learning leader for the COVID task force with Julie and Colette, and a lot of our classmates have participated in that both over the summer and in the fall. And I just want to say thank you to everybody because it really meant a lot to the patients, and people gave time like over our one free summer. And I just think that like speaks a lot to the people in this class and how much they care about helping patients. So that was a really good experience and made me really happy to see.
Thank you, Maria.
Hey everyone, I'm one of the service learning leaders for MEDS. Like Fanny was saying earlier, we basically had, last year when I got to volunteer for this program, basically we had kids come in and we taught them a lot and they were all very interested. But early on when we took over, we knew that we were gonna face challenges kind of transitioning this. So we first tried to transition this to all online curriculum, to still give these kids like the ability and access to health resources and education. But we knew that like one of the biggest challenges was shifting the whole curriculum to online, because since their school year started, they've basically been going remote learning, and it's kind of hard to force kids to endure another 3 hours on top of their normal education online only, and it can be pretty draining and taxing, as we can all attest to basically. So when we actually, I think even through these difficulties, I think we learned a lot about their school system and the difficulties these students are even facing, much more than we would have actually learned about them if everything was normal. Just because we had like many meetings with facilitators at the school to try and discuss how we can work and bring these kids to sessions that we can teach them all we wanted to teach them. Ultimately, we had to, we couldn't figure out a way to get this off the ground. And then by the time we thought we could maybe do it this semester, there weren't enough students to, who are actually interested for online only. So we're, at this point, we know that students are definitely interested, and we definitely want to expose them to healthcare careers, as well as teach them all the cool things we can teach them. But you know, at this point we can only try to make a curriculum that's can be adapted to online, so that next year, hopefully we can, if situations remain the same, we can maybe transition and have more success. Because now we kind of understand a lot more of the issues that were going to occur during the process. So yeah.
Thank you.
So I, in addition to being one of the service learning leaders for Helping Hands for Forgotten Feet, which Tyler already talked about, I was one of the ones that piloted the Trust program this year. And Simone did mention a bunch of it, so I won't kind of overlap with her too much. But basically, it stands for the Rural and Underserved Track. It's offered at Binghamton University, and this is the first year we're doing it with them. So we've had 3 sessions this year. The first one focused on rural health. The second one focused on people with intellectual and physical disabilities. And the third one, which is just this past weekend, focused on the LGBT plus community. We have another one planned for March focusing on veterans. So each session involves some sort of discussion about the nature of kind of barriers to health that the populations face. And there's also a panel that includes healthcare professionals and the members of the group from the population that we're talking about. And finally, there's a case study where we go through a kind of a specific patient story and discuss measures that we would take to ensure they get the care they need. So a pretty unique aspect of it is, as Simone mentioned, is that it's multidisciplinary. So besides the medical students, there's also nurses, social workers, and pharmacists that kind of all contribute their perspective on the case. So we kind of all learn from each other that way. And kind of what I think I've learned the most is to have a better understanding of how difficult it can be, like kind of the unique challenges different populations face in the healthcare system that I hadn't really thought about before. So, yeah.
All right, so we're going to transition to our presentation on vaccine hesitancy in a target population. It looks like someone's a little busy, but I can start explaining what's on the first slide. So essentially, we decided to take a little bit of a different route with this, with our target population. According to some studies, we found that the group that is most likely to be vaccine hesitant and the group that is most likely to have religious excuses or other excuses for not taking vaccines during the school year is, Simone, would you mind going a couple? Okay, here we go. So it was found that the exemptions grew more common within whiter and more affluent communities. So according to the National Immunization Study, white, affluent, educated parents are the least likely to choose HPV vaccination for their children. And a third study found that mothers who refused vaccines were most likely to be greater than 25 years of age, non-Hispanic, white, politically conservative, and living in the western part of the United States. So why does this matter to us? We hypothesize that this historical aversion to vaccines right now can be transferred over to COVID-19 vaccination. And so what's interesting about this is that there are other groups that are hesitant about vaccines, but their hesitancy can be more explained by historical experimentation and abuse of the medical system on that population, right? With this community, that historical basis isn't there. So why are they hesitant, right? Because if they're hesitant and they're not getting vaccinated, they can affect our most at-risk populations by interacting with them, right? These rich white people, they're going to the grocery stores, they're interacting with transport workers, they're interacting with blue-collar people, and they're putting them at risk if they're not vaccinated, right? So this all adds to the importance of understanding why this problem exists and how to fix it so that we can protect not only our rich white populations, but also the more at-risk communities that they interact with.
Okay, so just a little bit more about our target population. We found that children who are unvaccinated because of a parent's choice look significantly different, just like Sarah was just saying. They're more likely to be white, have a married, college-educated mother, and live in a household with an income of over $75,000 a year, and also more geographically clustered. And although vaccine refusal is referenced in gender neutral terms, it is kind of a gendered process, which is why we're saying like rich white moms, because women feel that they're responsible for navigating the meaning of like health, necessity, risk, and state interventions for their children. They just because of kind of how gender norms have developed, they really feel that this is their responsibility. So a lot of times it is the mother who is making the decision and has the vaccine hesitancy. So what are the reasons for vaccine hesitancy in affluent white women? There's a whole bunch of reasons, and some of them that we found were a persistent belief that vaccines can cause autism, like I'm sure all of you have heard, even though this article has been retracted, and we know that this study claiming this link was proven false. A lot of people either aren't aware of that or they still believe it. There's also fear of perceived unknown long-term side effects from the chemicals used to make vaccines. There's also a belief that vaccines may cause autoimmune disease in children, and it was found that hesitancy to vaccines may actually shift as the children grow up. So a lot of mothers are hesitant to getting their children vaccinated when they're young, but they do try to encourage their children to be vaccinated later in life as teenagers. So that was something I found interesting because I definitely didn't know that. A lot of them have an aversion just to it being when they're young children. They also don't agree with a one-size-fits-all vaccination schedule. So kind of similar to the previous point, they don't agree that each child should be getting these vaccines at the same age. They think it should be more individualized. There's also a belief that a healthy lifestyle and or breastfeeding the child will provide adequate immunity for them. So they think if they're exercising and they're feeding their children right and doing all these things, they'll already have superior immunity, so they don't need this vaccine. Or if they keep them really clean and they're not around germs, things like that, they won't be as at risk. And another thing that kind of goes along with that is a perceived ability to control their exposure to the things these vaccines protect against. So they think that if they can control who the child is interacting with and kind of keep them in a small bubble of either people who have been vaccinated or people they trust and think are responsible, then they don't see the need for vaccines in the child.
So this belief is spread throughout the community through social media mainly. There is an anti-vaccination network, essentially, and they have been proven to use bots and trolls that generate anti-vax propaganda, and they spread it very quickly across social media, especially Facebook and Twitter. There are Facebook groups completely dedicated to promoting this lifestyle, and it becomes such a strong belief system that people have likened it to a cult. Because of how aggressive these beliefs become in these Facebook groups. So propaganda includes the focus on the economics of pharma. So how much pharmaceutical companies make with these vaccines. That's a huge point of contention with the COVID-19 vaccine, saying that these companies are pushing them through as fast as possible so that they can make as much money as possible, and they're not actually going to help anyone. And they also have individual personal stories of children with allergic reactions to vaccines. So they promote distrust of big pharma and medicine while promoting social networks as a trusted source of health information. And then these Facebook mom groups and Twitter circles create this echo chamber, and it confirms fallacies, and health professionals don't have access to these groups because they're private Facebook groups. So doctors can't get in to create an alternative point of view and provide evidence or even to build trust, because it's hard to reach these groups.
Okay, so we'll be discussing underlying reasons first. So this is based on a study that was done, and it kind of took the continuum of vaccine behaviors from like never takers to sometimes takers and always takers, with significant differences between Black and white Americans. And I think it's a good framework to understand how white affluent families have vaccine hesitancy. So the degree of vaccine hesitancy is broken into three groups: complacency, convenience, and confidence. So like many of the reasons are stuff that Maria and Sarah just said. So for complacency, just assumption that the vaccine is not necessary due to low motivation, or the disease itself is a low perceived threat. And then convenience, this is like vaccine costs are too expensive or difficult to obtain. And confidence, as in fear of side effects or distrust in just broad organizations, or a more generalized sense of distrust that stems from tradition. This is usually not the case for white families though. So in the case of affluent white families, complacency and confidence are really the broad categories that we want to target. And they clearly impact vaccine behavior, often more profoundly than the convenience issue. Ultimately, when complacent individuals, they usually took the vaccine most often due to doctors' recommendations, which usually overcomes the ambivalence towards the vaccine. And in regards to confidence, usually the individuals that aren't confident in the vaccine are only going to take it if the trust is built up from different sources. Okay, so some of the strategies that we can use, and these are based on studies that have been done. Basically, one of the biggest ones is having trusted leaders in affluent communities actively promote getting vaccinated. And this is usually very good information because it empowers members of the public to advocate for themselves and their loved ones, especially in echo chambers, like Sarah was saying, because they're usually polarized against one view, and it's usually someone in that community can kind of break them out of it. providing doctors and pharmacists with information resources to guide patients. I think this is very important, especially motivational interviewing, which is a goal-oriented collaborative counseling style that can persuade patients to take vaccines. And then the vaccination presented as a public act is kind of tying in with the trusted sources, because it kind of provides another point of trust for the patients to use as a reference. I also, there's provide financial incentives like tax credits for vaccinations of their children. This was done in Australia, and a study that found that it can actually boost the number of individuals that actually get their vaccine. But it's more on a broad governmental level, and it's very hard to implement. And from certain patients' perspectives, it can seem oppressive, so it might reduce trust in the vaccine over a period of time. So it's kind of a risky strategy.
So I will finish off. So the one extremely important strategy is to kind of put targeted advertising in the community with good information about the vaccine. And I want to read this kind of great excerpt from a paper I read to kind of give an example of how something like this might functionally work in practice. So let's assume a woman named Jane, who is a mother of school-age kids and is suffering from diabetes, and who is skeptical of the COVID-19 vaccine for both her and her child. At work, Jane encounters CDC infographics depicting that individuals with diabetes are at an increased risk for severe illness. Next to the sign is a QR code, which leads to a website listing vaccination centers in her area. Jane takes a look, but is worried about the cost and safety for her and her child. On the way home from work, Jane stops to pick up her child from school. Her child gets in a car and presents Jane with a flyer distributed to all students in her town containing a list of local health centers providing free COVID-19 vaccines and displaying the same QR code from work. Later on, Jane decides to scroll through social media, and as she opens the app, there's a pop-up saying, "Protect your child from COVID-19. Having been repeatedly exposed to the benefits, affordability, and safety of the vaccine, Jane decides to click the QR code and make an appointment for her child to get vaccinated. And while this is admittedly an idealized scenario, kind of establishes the level of preparation and collaboration needed to successfully educate the public to encourage the kind of widespread vaccination that we need. And then one final vaccine strategy is to give it at non-traditional distribution sites. They mentioned this in the last presentation. And it has a couple of different benefits. So it's very convenient, as they said, and decreases the barriers to vaccination. This is less important for kind of our demographic and more for the rural population they talked about last presentation. And then, as Aditya said, it kind of makes getting vaccinated a public act, which may help normalize it for people who may be hesitant, since they're able to see other members of their community doing it as well. Something that's similar in effect would be to giving like stickers out, like we do for donating blood, kind of encouraging patients to post pictures on social media to kind of let social media work for us. And finally, I wanted to mention, I looked up kind of vaccine mandates just because I was curious if that was like even possible. And basically the literature suggests that it would be pretty problematic to do, especially for the COVID vaccine, for a few reasons. The first is that currently the vaccine has an emergency use authorization. So we would need much longer term safety data before they could even consider mandating it. Another reason is that obviously it kind of undermines patient autonomy, which could lead to backlash and decreased public support, since it would sort of change the narrative from do this because it's the right thing to do and because the science is compelling to do this because we said so. And that would kind of give the impression that the science isn't compelling on its own. So that isn't what we want. And then also it would be extremely difficult to enforce that, kind of practically speaking. And that should be it.
Great. Thank you. Both groups have provided very compelling arguments and strategies for addressing vaccine hesitancy. Our last group is going forward.
All right, hello everyone. My name is Robert, and I am one of the SLLs for the Rama Health Clinic this year. And once again, I'm sure Mike and Maria already talked about it, but our organization provides work physicals, longitudinal care, and access to laboratory testing at no charge to adults in the local community. And this year, every single SLL chose a specific responsibility to take on additionally to the main outreach that we normally do already. And then for me personally, I chose to help the clinic leadership coordinate COVID-19 related changes. And this kind of exposed me to a lot of like regulatory challenges that small free clinics have to face and overcome just to be able to legally provide healthcare to the community. So then some of the specific things I had to do was to make sure the clinic met the CDC and New York State pandemic regulations. And we also had to screen every single patient prior to their appointments. So we would call them remotely the day before the clinic visit just to make sure they're symptom free. And yeah, so because of this work, we were able to reopen our clinic in late July, early August, and we had it running until November. And then we're actually planning to reopen again this month after being closed for most of the holidays. And this experience basically helped me it really like put a face to all the issues we learned in class. The patient population that we served was very similar to the patients we highlight in class. Most of them were either non-English speakers, refugees from other countries, or Black Americans. And yeah.
So Apeksha and I are the service learning leaders for refugee health literacy this year. And what we do is every week, so we engage in weekly educational sessions with high school students from the refugee community on broad topics, from everything including preventative care, primary care, and chronic conditions. So this year we reached out to the youth coordinator at Northside CYO to set up weekly sessions with high school students, intending to continue in person, but that quickly changed. So in order to ensure that our sessions would be useful to students, we met with a few high school students in person to ask about which health topics they had questions on and wanted to learn more about. So some of the questions we got were, why do we need a physical to play soccer in school? Why do we get blood drawn? They give us vaccines, but don't explain why. What's the flu shot? Why is it called coronavirus, et cetera. So soon after our meeting, CYO was shut down for in-person sessions again. So we decided to transition online to provide sessions via Zoom on all of these topics. And one of the big challenges that we had, or still have, is low attendance, understandably. And that is partly due to the fact that there's no incentive to really attend these sessions online like there were in person at CYO. However, we've seen that
in our group is in the chat right now, so we might want to move on to the next slide.
Oh, sure, go ahead.
So I am the first person to talk about Women's Heal. I worked with Natalie to help run this program. It's at the rescue mission. We already know a little bit about the rescue mission from the Helping Hands for Forgotten Feet. Same place, slightly different population in that we really focus on the women at the shelter, but you know, if it's about art projects and stress relief. So if men want to join in, that they're perfectly welcome. So the goal is to really provide a safe space and a location for people to come and do art when they want. And we provide all the materials, and we have a few of us students just doing the art projects there, helping lead it, and they are really able to do whatever they want. So we had a bunch of good sessions, even up to when everything closed down. We were able to, a big challenge there was trying to figure out how to keep everyone socially distanced, how we're gonna make projects that people aren't sharing, like paintbrushes and materials. And so that, you know, we had to make a bunch of modifications in that way. Our attendance was already really low because the shelter had variable populations staying there at that time. But the biggest challenge that I would say was educating the clients of the rescue mission about the importance of wearing a mask, washing your hands, and making this, at least when you're with us in this room, trying to make it a priority. Because, you know, in their life right now, housing insecurity and, you know, having a stable home, having food is their priority, rightly. And so they definitely at the bottom of their priority list is going to be, you know, being safe. Some of them don't believe in the virus. Some of them do, and they have a lot of mental health problems, and that just compounds them and makes them super anxious. So that was definitely the biggest challenge, was to accurately portray and give them the right information about about the virus, what's out there, how to stay safe, and what we hope they do when they enter the room with us, keeping their mask on, washing their hands, etc. So I think we did a pretty good job with that. Of course, when things shut down, this program specifically, we can't get them art materials easily. And we can't, you know, lead remotely, because getting multiple people the same art materials and the rescue mission the same art materials was really difficult. So we didn't end up doing anything remotely. But we're excited for it to come back. We had a really great group of students who had a lot of enthusiasm to work with this population of people. Thank you.
Thank you. I apologize. Neely, did I cut you off? I'm sorry.
Oh, no, that's fine. I was pretty much done.
Okay. My apologies.
No worries.
Sorry, I cut you off because my audio cut off.
Oh, no
I
worries.
thought no one was speaking at the time.
All right. So our next one is Bethany.
So I was the SLL for Jerry Care, which is a program in which we visit patients in the hospital over the age of 65. We just talk to them about their home lives. We help them fill out these whiteboards that they have in their rooms that say about me, like their favorite foods and stuff like that. Obviously, this was completely off the table this year. So then I was assigned with organizing the COVID volunteers to go to the COVID testing site at the fairgrounds, which understandably we didn't have a whole lot of takers because that is putting yourself at risk. But we did have a lot of nursing students take advantage of it, which I found really nice to get a mix of the different colleges. And then for myself, I did a lot of the remote COVID task force organized by Colette, Maria, and Julie, which was run super well. And from that, and also from the testing site, it really shows how confusing all of this is for people who have education in science, and especially for those who don't. A lot of patients in the hospital struggled with, what's my family supposed to be doing now that I've tested positive, and how do they stay away from each other, when to get tested, and even like what are the signs and symptoms of COVID. And then all of that, I was really impressed with how all the different facets at the hospital like helped answer those questions for these patients. So that's what I learned. So our target population that we chose to focus on is Black Americans. As we've seen throughout the pandemic, they've been infected at a much higher rate. They've been infected at a rate 1.4 times higher than white Americans, and have died of COVID at a rate 2.8 times that of white Americans. And another reason that they need to be educated on vaccine hesitancy is because of the systemic issues we learned in class that predisposes them to chronic disease. Black Americans have higher rates of diabetes, obesity, hypertension, heart disease, asthma, and all of those we've seen are linked to more severe cases of COVID. We've also seen that Black Americans have greater exposure through multi-generational housing, public transportation, and then careers that are not conducive to working from home. I found this to be pretty staggering. In 2018, it was reported 27% of Black Americans lived in multi-generational housing compared to only 16% of white Americans. And then lastly, an important note on this population is the differences in health literacy. In 2003, which is a little outdated, but still stands, it was found that 58% of African Americans had basic or below basic health literacy compared to 28% of non-Hispanic whites. And they've found that low health literacy is used to predict disparities in health behaviors, access to healthcare resources, and health outcomes. And for all of the reasons we learned in class this year, systemic factors such as limited educational opportunities, racism, health system mistrust, and a lack of culturally tailored health information and services.
So this past November, the Pew Research Center conducted a survey that showed that while about 60% of Americans say that they'll definitely or probably get a COVID-19 vaccine, only about 42% of Black adults say they would. And that's compared to 83% of Asian, 63% of Latinx, and 61% of white adults. And this vaccine hesitancy is rooted in a distrust of medical institutions. So a 2002 JAMA internal medicine study found that even after controlling for markers of social class, compared with white Americans, Black Americans were more likely to believe that physicians would ask them to participate in harmful research, expose them to unnecessary risks, not fully explain the research, or treat them as part of an experiment without their consent. And we can all think back to the Tuskegee study that was conducted by the US Public Health Service from 1932 to 1972 that involved Black men who thought that they were receiving free healthcare, but were instead involved in a study without their knowledge or consent on the effects of untreated syphilis. And although this study does serve as an example, we know that it's not an isolated event. And Dr. Corby Smith and her co-authors who published the JAMA article wrote that distrust in medicine and research may be rooted in experiences extending back to slavery and continuing to the present day. So to understand and address vaccine hesitancy and the roots of medical mistrust among Black Americans, we have to look at Tuskegee not as an isolated event, but rather as one component of structural racism that requires structural solutions. Dr. Kim Gallen, who is an associate professor of history at Purdue University and the founder and executive director of COVID Black, which is a collective and an early response task force on Black health and data, says that what is needed is for predominantly white institutions to trust Black physicians and Black researchers to implement the cultural approaches they know will work within Black communities. And that's going to mean to give time and resources to those Black institutions and doctors and healthcare providers so they can go into the Black communities and engage in strategies that are going to be really effective. So with that said, I'll let Colette and Rob talk more about some of the proposed strategies.
Yeah, so what Nakeia just talked about ties directly into some of the proposed strategies for tackling this disparity in vaccine hesitancy seen in the Black community. So one of the main things, like other groups talked about before us, we need relatable messaging, right? It needs to be targeted, it needs to be relatable. So social media would be one great way to use, one great thing to use for that. It's free, it's accessible. Many people use it, especially people who are hesitant to get their vaccines. It also makes doctors look more amicable, relatable. So the message will be more likely to be accepted on the other side. And then another aspect of being relatable is where that message is coming from or who that's coming from. So this is related to what Nakeia was just talking about how we need more Black doctors and Black leaders in science to get that messaging across. So in the study that was published just last month in the Annals of Internal Medicine, it was found that messages from racially concordant physicians increased information-seeking behavior of Black participants compared to messages from racially discordant physicians, right? So some of the more successful examples I found right now, who like Black doctors who are currently posting very actively on social media to get Black Americans and all Americans to be less hesitant about vaccines would be Dr. Krista Marie Collins, who's pictured to the right on TikTok with like almost 60,000 likes on TikTok and many, many more views, and also Dr. Robert Drummond. And but like these two doctors are just very specific examples of how to convey a health message. But then there's actually bigger structural and institutional changes we can also make. And one of them would be more diversity in medicine, right? So the Black population in the US currently is about 13%, but then only 5% of all physicians in the US are Black, right? So then this shows that there's a lack of diversity in medicine, and we need to fix that underrepresentation in order for the health messaging to be more relatable in the future.
So tying into that messaging theme, personal outreach is more likely to be successful. And it doesn't just have to be personal outreach from, just your friends or just your physician, but having that method of having accurate information come from various sources around your own community, people that you trust, will increase the probability that these individuals will get the vaccine, because they've seen their neighbors get it, they've seen their priests get it, they've heard from their primary care physician or NP or nurse to get this vaccine. They've seen people come out on the other side okay and understand that this is an important public health strategy because of that. A great example is Dr. Dykes hosted a town hall, just specifically talking to people within the community, within the Syracuse community, to say, hey, we recognize what has gone on in the past. You have a right to be skeptical, and we understand. And right now, let me give you the accurate information so that we can work together as a community to have higher vaccination and have a healthier community as a whole. On the opposite side of that, but something that is equally important, is a nationally coordinated strategy. Something we saw the other day, as of January 28, was that in New York City, while only 24% of the city residents are Black, 24% are Black, only 11% of those vaccine recipients, the people that signed up and got their first doses, were. So only half of them are getting the vaccine. And that's not because of the hesitancy per se, but it's actually because of white New Yorkers coming in to take those appointments. Obviously, it's multifactorial, but that is, to me, is very shocking to hear, and just proves how we need some way to encourage and enable people who are willing to get the vaccine to have those spots available and to get both doses of the vaccine. And this must include the knowledge that a lot of these people are not able to, transport 2 hours in their own car to take that appointment. Like my dad can drive 2 hours to Utica to go get an appointment in March, but that's not possible for many other people. So we have to make it a plan, a nationally coordinated strategy for individuals like this to ensure that they have appointments within their own community. I think that's our last slide. Does anyone have any questions?
Any questions for any of the groups? That was fantastic. I applaud you all for a great presentation, lots of great information and resources to share. I thank you all for your participation this year. I know it's been hectic and frustrating and sometimes just disappointing, but you guys stuck it out, and I really appreciate your flexibility this year. Nakeia and I, like I said, we we were trying to figure out how to do service learning from a distance and in a safe manner and still provide a quality and unique learning experience. But I hope that this year we were able to accomplish that. So again, thank you. Thank you especially to Dr. Feuerstein for all of your support and help throughout this year and the coming years.
It's my pleasure. I get a lot of joy, as Dr. Duan was talking about, from this part of what I do as a doctor. And it really just sustains me to keep on going some days.
On that note, if anyone else has any questions, comments, Nakeia, did you have anything to add or want to add?
I was just going to echo what you said already about the presentations. Thank you all for, doing the work and, adding to it as we had to pivot, sort of take the COVID pivot with your experience, this year. So I definitely appreciate the conversations that can be started as a result of your presentations, and I thank you for putting them together, presented very well. I enjoyed engaging in this space with you all this year. I enjoyed reading reflections and different things like that. I'm still, putting together my words to respond to you all collectively. But I feel like mission accomplished with engaging you all this year. So I thank you. Thank you for your.
Awesome. Just a quick reminder, our next set of groups are going on the 15th. So definitely the same Zoom link will be utilized and will be valid. So definitely tune in for that. If you haven't yet uploaded your PowerPoint presentations, please do so by the end of today, so I can get them ready for our next session on the 15th. Secondly, service learning leader applications are out. So please, the link was sent out last Friday. So please encourage first year students, volunteers who participated in any of your programs to, look at the application and apply. Again, given the COVID situation, we have no idea what things are going to look like for next year, but we are willing to engage and plan accordingly and hopefully develop some really good learning experience for the next group of service learning leaders. So definitely promote. And if anyone has any questions, send them our way. The only program that we're not recruiting for right now is Roto, because Roto is all set. We have our service learning leaders for another year, I believe. But if you have any questions or run into challenges, definitely reach out to us and we can try to help. All right. Well, thank you again and enjoy the rest of your day.